Hello, everyone. I'm Paul Irwin, Dean of the UAB School of Public Health. I am excited to welcome you today to our 2024 Carole W. Samuelson Endowed Lecture in Public Health Practice. Before I introduce this year's award recipient and keynote speaker, allow me to briefly share more about this prestigious lectureship. Dr. Carole Samuelson served as the health officer, the director of Jefferson County Department of Health from 1985 until 2002. The Carole W. Samuelson Endowed Lectureship in Public Health Practice was established in 2002 by family, friends, and colleagues of Dr. Samuelson to recognize her courage, tenacity, and leadership in promoting quality health and educational services to the public. This endowed lectureship is one of the most highly regarded at the University of Alabama at Birmingham and honors Dr. Samuelson for her outstanding service through years of devoted commitment to the Jefferson County Department of Health, as well as many other community and statewide organizations interested in providing quality health care. In all her professional and community activities, Dr. Samuelson led with diligence and innovation, while always placing the public first. Each year, a recipient is selected to honor her passion for excellence, as well as to continue her tradition of intellectual innovation and community involvement. I'd like to now introduce our 2024 recipient, Dr. Rahul Gupta. Dr. Gupta is the first physician to serve as the Director of National Drug Control Policy and lead the Office of National Drug Control Policy, the ONDCP, a component of the Executive Office of the President. He has been practicing primary care for more than 25 years and has served in private practice and in public health in towns as small as 1,800 residents and in cities as large as 25 million. Additionally, he has served as a local public health official and as the West Virginia Health Commissioner, where he brought together public health, law enforcement, healthcare, faith-based leaders, and business partners to solve public health challenges in novel ways. His lifelong commitment to educating the next generation of physicians and policymakers has led him to hold academic appointments throughout his career, including as a clinical professor in the Department of Medicine at Georgetown University School of Medicine, and as visiting faculty at the Harvard University T.H. Chan School of Public Health. A passion for global health led him to join the March of Dimes as Chief Medical and Health Officer and Senior Vice President, where he provided strategic oversight for the organization's domestic and global medical and public health efforts. Having received his Master of Public Health from the UAB School of Public Health in 2006, and through his work as a physician, researcher, a state and local leader, and educator and senior leader of a national nonprofit organization, Dr. Gupta has dedicated his career to improving public health and public safety. Please join me in congratulating and welcoming Dr. Rahul Gupta, this year's recipient of a Carole Samuelson Endowed Lectureship in Public Health Practice.
Thank you, Dean Irwin, for the kind introduction and for the awards and for inviting me back to the campus. I also want to thank your team, which have been so tremendous, and especially Sarah Hendren from the alumni office for making this possible. I know we have so many folks here today. Appreciate both Jefferson County as well as state officials, my colleague Dr. Singh. It's really good to be with you, and I bring you with me greetings from President Biden and Vice President Harris. I was honored to receive the Alumni of the Year award last year, and it's so important and good for me to be back here. I will say that, as Dean Irwin mentioned, Dr. Samuelson, as Jefferson County Health Officer, symbolized courage in leadership. I know that because I've been in her shoes as a local county health officer. So what I'm going to do today is talk about where we are from a perspective, talk about my journey, and then come back to solutions. So if you look at this chart, you will see that unintentional injury contributes to more years of potential life loss than any other cause. And if you see here, the drug epidemic tops that list. You can start to see the dark shadows here on the top. In 2000s really began the rise. In about 2010s or so, it took over the motor vehicle crashes and other reasons. And now it dominates the unintentional injury deaths across the United States. Now, the exponential rise in the past 2 decades is one factor that distinguishes this from anything the previous generations have experienced. Now, let's look at it in a different way. If you see the reds of the county level data, this is what we're seeing all the way from early 2000s to recent most. And you see this because this is how fast and how quick this epidemic has happened. We'll talk a little bit about why and how, but this is very important. The most provisional data shows us that from CDC that there was 105,000 plus deaths from overdose last year. Now, that number is really, really important. Yet, that number is also just the tip of the iceberg. If you look at this, so many more people suffer from what we call non-fatal overdoses. And as you look at this pyramid that we were able to articulate in general medicine, is to say, it is not only the tip, we have to look at the rest of the pyramid. Beneath that, you see the number of people suffering from opioid use disorder. It's about 8 million people across the United States, and only a fraction of them get the treatment that they need. Overall, we have about 48 million people suffering from SUD or substance use disorder across this country. Now, of course, part of this is being driven by illicit opioids like fentanyl, meth, cocaine, and others. But also, another factor that's not what it used to be is this is a polysubstance use epidemic. Polysubstance means, we used to see people who would take stimulants or depressants, but not both, and not either. Now, if you go and see on street drugs, you will see a mixture of both. So polysubstance use has become the norm. Now, if this doesn't convince you that this is a really important challenge for a country to face, I'll share with you the economic data. Now, in 2017, we lost $1 trillion of our GDP economy just in the opioid uses. In 2022, by congressional estimates, we lost 1.5 trillion. It so happened in 2020, entire Russia's GDP was also 1.5 trillion. So we're losing at least the equivalent of Russia's GDP each year because of this. Now, this is really important because in a $27 trillion economy, you're talking about 5% loss from just one epidemic, which is huge, and it's not sustainable. Now, why does this so much matter to Americans? Well, first of all, we know so many in this room and other rooms that I go to, people have been impacted. In fact, there's hardly anyone whose family or friends or someone they know has not been impacted. American people view this as the greatest threat to public health, 13 times more than COVID, 13 times, and more than twice as threatening as cancer. And while there's a lot of debate of what should be done, but the clear fact is this is going to and continues to play a big role in both policy and politics. Now, here's another convincing ability to convince you guys. Life expectancy, if you look at the chart above, the green line is the United States life expectancy over the years, and the blue line is of the other countries, developed countries, has been going down. Now, as public health officials and public health practitioners and those in training, that this is very important. So it began to go down prior to COVID. It has continued to go down. And as it ticks up, it is still not caught up with other countries that were during the COVID. So compared to other countries, we have not rebounded still. Now, on top of that, I'm going to show you another figure. Our fertility rates is the lowest it has ever been on record in US history. And it is a number one killer for people 25 to 49, meaning the working age population. So if you combine these facts together, we've not had a threat like this before. And that's why this isn't a red state issue or a blue state issue. This is America's issue. And it affects every community. So I've hopefully described to you the problem we're facing. So in the White House, it's really important to figure out how do we address the problem as the senior most policy control advisor to the president. One of the things we try to do is, address this, but I'll talk about those. But let me talk about my journey a little bit before. Now, how many of you have gone to a small town called Florala, if you could raise your hands? Oh my gosh, too many. My house is right there on the interstate. So you see that board down there, and the house is 1 mile up. And I started my career in a double wide trailer as a clinical practice in Florala, Alabama. And while it was a beautiful town, I was trained in internal medicine. But what I got to see was I was an ER doctor. I was a community doctor. I was a doctor at 9:30 at night when they knocked on my house because they wanted me to see them. So I was everyone to everybody in the town when I was there. But what really changed was, I moved there around in year 2000 or so. Post 9/11, I'll tell you a story. The day after 9/11, 2001, I come to my office normally, routinely, about a little bit before 8 a.m. from the back door, patients waiting to see patients routine. My secretary comes to me and says, "Doc, there's a couple FBI agents that are waiting on you." And I'm like, that's interesting. You obviously get a little bit of panic because it's the day after 9/11. You, put yourself in right posture and say, "Sure, send them back in." Would like to know what it's about. They come walking in with a few prescriptions in their hands. And they say, "We're here conducting investigation. I would really need to know if you signed these or not." These prescriptions were fake prescriptions for opioids. And that began, or at least highlighted for me, the issue right there and then in 2001, why this was a huge issue. But then again, I also had, at the same time, veterans come in and other elderly patients who were crying, frankly crying. Because on one hand, they knew we were going to be engaging a lot of confrontation across the world, but they were having to struggle between deciding to have food or have their medications. Having seen this, and having seen patients of mine that were either dying in my arms from overdose or getting arrested for distribution, while getting paid sometimes in homegrown tomatoes and apple pie, I thought we need to make a change. I've got to figure out and better understand policy and better understand what can we do, and I do as a physician trained, to learn and impact better in terms of health policy change, as opposed to only individual patient change. So what did I do? I turned to the best place I could in my neighborhood, and that was right here. And so I joined not only the full-time faculty here, but the part-time MPH course. So what would happen is during the week, I was a full-time faculty in a hospital at Huntsville Hospital as assistant professor at UAB. And on weekends, I was at MPH students right here in the Rahul's building, focusing on healthcare organizations and health policy. And let me tell you, I had 2 young kids at home and a spouse in residency training at the same time. So for all of you working parents And those that are working, I get it. And I continue to be amazed at what you all can do every single day to make it happen. But the program really helped me. It helped me better understand, not just become a manager, but also become a leader. The UAB's programs focus on evidence and data-driven decisions in public health, whether it's response to disasters, disease, epidemics, became key pillars of my work in the future. Those trainings, hands-on, oftentimes, were really important to me as who I would become. And each one of my courses, I'll tell you, it allowed me to obtain the leadership skills that I would, to understand the difference between managing people and leading. Because this is about a lot of the work that is get done about it. I mentioned about the White House, it's about leadership, in addition to being managed. But what I learned here not only led me to take increasingly challenging and rewarding roles in public health, including as a state and local health officer, it also began to get me to understand my authentic self, because that's at the heart of core public health leadership. As you can see, I put out a picture of an onion. And as you can see the layers of the onion, the authentic self is really in the middle. And if you start peeling the layers, the smells keep getting worse, and that's a problem. But you see, to succeed, it becomes critical that you examine not only your desires and strengths and weaknesses, but also your motivations and your values, as well as understand your blind spots and shadow sides, really the primitive sides of us, and be able to figure out how to best manage that. The program really helped me do that. Now, what I recognized and realized was, look, many of us get taught here the technical intelligence, the technical know-how. We bring with us some level of cognitive intelligence or IQ, but it's really the emotional intelligence, the EQ, that is at the center of what we do and how we do it moving forward. And the sweet spot is when we can figure out how to use our EQ, IQ, and the technical skills. And the combination of those is so critical to success. Let me give you a couple examples, but I'll start out first by, I moved to become a local health officer in the largest county in West Virginia, Kanawha County, seat to the state capital. And one of the things that I went, like many of you will, numerous public health challenges, whether it was chemical disasters, it was my second day, I had the first death of a teen from flu that was ever on the record in the state. Went through H1N1 pandemic, and obviously the opioid epidemic. But what is always was critical and important for me was this, that public health is not just about being prepared. It's actually being prepared to adapt to whatever comes next. And that's kind of what's been a part of me and part of the important values. Now, let me ask you a question again. Let me say, what would you say if people asked you right now today if your water is safe to drink? Raise your hands if you think the drinking water coming out of your taps is safe to drink. Okay, so everybody raise their hand, safe to drink. So simple word like safe. Everybody's, yes, it's safe to drink. Well, let me give you an example that I dealt with. So I was sitting in a DC meeting on evening of January 9th, and I get a call from one of my environmental health directors. I was a local health officer there. And she said, well, Doc, there is a leak, okay? We have 5,000 leaks into the water every year in West Virginia, Chemical Valley. So, well, the leak, it's bad because when I open the tap, it smells bad. Actually knew this is not good. It's not one of those 4,999 leaks. To be able to identify the big one. So at the time, I gave her instructions and I said, well, call me back. We got to shut down this, and I'll talk about that in a minute. I called my wife right away. with two little kids. I said, honey, let me ask you, what's your dinner plans? She's like, yeah, we're going out to dinner. I said, I think you may want to cancel that and go out and get some bottled water. She's like, are you crazy and all of that? And I said, no, I'm just telling you, because there probably will be riots afterwards for water. Can't tell you more than that. So what happened was at 6 o'clock or so, the governor declared a state of emergency. About 4 a.m. next morning, President Obama declared a federal emergency. But what had happened was a cold cleaning chemical, 10,000 plus gallons with multiple other chemicals, had spilled. That is exactly the tank that spilled it from into the waterways. That is an uptake for one of the largest American water plants in the country that serves 300,000 people. So we had a do not use order. This was the largest chemical contamination of drinking water in the US history. And this was way before we even knew the issues of Flint, Michigan. And what happened at the time was that this was state capitol. It happened to be the 60-day legislative session. So the legislature was in town. We usually don't like to have disasters, but if they are happening, when they see it firsthand, they are more likely to act. So this is the river stream in green, and in the red inset is a number of 9 counties. Mine too were the largest, and I was responsible for it as a local health official. And what we did initially, we immediately closed. This is again public health 101. There's no blueprint to go to. There's no textbook to read. You have to deal with things on the fly. So we closed all the permitted facilities. That means restaurants, schools, all of those things. We did water distribution. We fielded about 5,000 calls for a small health department in an evening, 5,000 calls plus. We created, there were about 2,000 facilities, 100 schools, and so many more that we closed down. Over the days, we distributed about 3.5 million gallons of water, including state distribution. You can see the numbers. And that was a time when there was Arctic blast. So you can bring a tank of water, but guess what? It freezes up. It won't come out. So now you have to store those tanks in a heated place. Those tanks are large. There aren't a lot of storing places. So unique challenges you have to come across. But as we went through this led to a congressional hearing, field hearing, where you see who's now the Senator of Capitol in West Virginia. It was Senator Manchin and others. But the question was asked by every state and federal official, is the water safe? And the story headlines the next day was, they want to answer the question, as you can see that. At the same time, on the CDC website, it said there should be this particular chemical, MCHF, in your drinking water. So the lesson here it becomes that how do you convey truth and with honesty to the public in real time, in a way that you maintain your reputation, but also garner confidence in the public. I will say, if you get a chance to, Evan Osnos did a great New Yorker article on this. It's called Chemical Valley, to look it up. It's a good depiction of policy and politics. So it comes back to the components of emotional intelligence at work. And why this becomes important, basically, is that it is a core-requisite of public health. With self-awareness, you're able to have accurate self-assessment and impact on others. So you can see from self-awareness, everything begins to flow. And this manifests both as social awareness as well as self-management. These features ultimately result in positive relationship management, which is a part of being an authentic leader. Look, there's always going to be those who will question your actions. There's no doubt about that in hindsight. But I would remind you what Martin Luther King Jr. said, that the ultimate measure of a person is not where they stand in the moments of comfort and convenience, but where they stand at the times of challenge and controversy. That's what becomes important. So, my guiding principles always have been that people don't care how much you know until they know how much you care. So it's really important to convey that information in a manner that's accurate, truthful, and honest, and timely. It's a critical piece when you're dealing with, especially environmental health disasters. And so at times this was difficult, but it ended up that the governor asked me to be the commissioner at the time. And you're going to take risks. If you're in a job, you're going to have to take risks. So I served afterwards for two governors, both a Democrat and a Republican, including the current governor. But my policies were always based on data and evidence. But that doesn't mean they were always popular from the start. Sometimes you got to convince people to take the right path, and including your bosses. And you're going to begin to see a lasting impact once that happens with that confidence. And what we did in West Virginia was, first I came out and I said, look, the job of the commissioner is to commission reports. So where are we with the last 15 years of the drug epidemic? West Virginia being the ground zero. We have more overdose deaths in West Virginia than any other state. It turned out we didn't have those reports. What is there in a link with HIV, with hepatitis, with other communicable diseases? There were no reports. So then we began to weave in and develop data to understand the true aspect of this syndemic, which it really is. And with those reports, then we tried to then look at a social autopsy. That social autopsy, so if you think about study, right, you're looking at, we're taking a sample size, N has to have power, all of those things, like alpha error, beta error, right? We looked at the entire 1 year deaths from overdose, all of them, 100%, the gold standard of a study. And we conducted a social autopsy of all of them. We looked at how much education they had, what kind of job they had, how did they die, how many times they went to medical facilities, how many times 911 was called, what kind of insurance they had, were they married, were they blue collar, white collar, everything. And we came out with very important policies that ultimately were implemented afterwards in the legislative session, creating a state drug czar's office, creating a naloxone carry antidote mandated for everybody, expanding number of aspects of treatment and treatment behind the walls. But that only happens if you have evidence, and if it's not there, then you have to find the evidence to do it. So fast forward to my current role at the White House. You know, the ONDCP has been operational since 1989. And what it basically does is it looks at all of the drug control budget and has that authority over all of the agencies. And I'll talk about which agencies, but it basically coordinates the budget of about $44 billion and produces the president's national drug control strategy every 2 years. So we have about 19 agencies, everything from Department of Health, NIH, FDA, SAMHSA, CDC, to Department of Justice, DEA, Department of Defense, Education, Postal Service, and so many others. So part public health and medical, part national security. And we're coordinating the actions because this is such an important epidemic of all of these agencies to make sure that actual policy is impactful and is data-driven. But, you know, things have changed, and this is important. Let me ask anybody, does anyone know here how many people died from an overdose in 1989? A guess? Not UCs. Well, 9,000. 9,000. We have right now 9,000 people dying each month. So that's why this is so different. The truth is the world has changed so much in the last 35 years. In 1989, if you wanted to make a phone call while you were out, you had to find a payphone. If you wanted to take a photo and share it right away, like we all do all the time, CIS has been doing that all day today, I hope you brought your Polaroid camera. And if you wanted to, you know, record your kids' school play, you had to bring a camcorder and a VHS tape. Now, all of these things can be done here in one thing, right here. So this is how much the world has changed, and we have to have drug policy follow that. And that's what we are dealing with. So if you look at this chart, I talked about 105,000 lives cut short, one every 5 minutes, representing empty classroom seats, representing empty chairs at dinner table all across America. But why? You have to ask yourself why. Because for hundreds and hundreds of years, humans have lived side by side with drugs, but they were plant-based drugs like cocaine, marijuana, heroin, poppy. But what's happened in less than last decade, is that now with synthetic drugs, from chemicals, you can create the most lethal substances on earth ever made. All you need is a chemistry set, simple, internet, and one-bedroom apartment. And you could cause all the lethality. So the game has changed. And synthetic opioids like fentanyl, they're responsible for about 70,000 of the deaths. 3 out of 4, roughly, of all the deaths. And this is a global problem. This is not something that we see is limited to the United States. And that's why last April, I declared xylazine, which is an animal tranquilizer, or called tranq on the streets, that is being mixed in with fentanyl, an emerging threat. So we can work on it faster, not wait another 10 years for it. But this is important. Now, having said that, here in Alabama, we lost nearly 1,500 people in 2022, mostly from fentanyl, but also from meth and cocaine. But it did not happen overnight. It happened first as we changed our standards to prescribe opioids in the early 2000s. I was right there, on the ground, seeing patients and being marketed to several times a week, if not every day, with these opioids. And we had more opioid prescriptions, the article says, than people. All those excessively dispensed prescriptions were being accessed by people that were not prescribed these opioids. So you would say, okay, that got further up. But then, if you look at here, from 2017 onwards, we started to have declining in the prescribing, the opioid prescription rates. So the question is, when we began to see a decline in prescribing, death rates kept rising. Death rates did not stop. They kept rising. Anyone knows here why? So what happened was because of as we cut down on prescriptions, there was the availability of more affordable, more accessible street drugs like heroin, which now later became mixed with fentanyl. So the deaths did not stop. And now fentanyl is dominating the overdose deaths. So that's where we found ourselves when I came into the office after being Senate confirmed, a drug epidemic that was supercharged with the most dynamic and lethal drug supply ever. And right now, when we look at this, we're facing a significant challenge. And it means that we can't continue to do what we've been always doing and expect different results. With a new era of drug threats, it mandates a new era of drug policy. So we've got to move past the yesterday's way of doing things and go into the future. What does that look like? We knew when we came into office that the problem would only get worse if we kept doing the old things. So we made the greatest transformation that has been made so far in our nation's history to address this in more than half a century. What does that mean? Well, that means, first of all, the president's strategy we put out in 2022 is now focused on both helping people with addiction and recognizing addiction as a disease, and going after drug trafficking and its profits. Doing both, two sides of the same coin, not either or, but both. So that became an important piece. And then the president announced this as part of the unity agenda, where unity agenda means where people from all walks of life, all ideologies can come together to solve problems because they're too important to play politics over. And so we began to work on this to get big things done. And I tell you, this is a big thing. Now, let me tell you some of the actions. We put in about $211 billion already to prevent overdoses and save lives, more than any previous administration. Just from the State Opioid Response Grant, or SOR grants, we've gotten an investment of over $33 million into the state of Alabama already in the last couple of years. We have naloxone, or Narcan, that you see up there, that's available now over the counter, often sitting right next to Motrin and Tylenol. And it's these grants have helped save and buy about 10 million kits of naloxone. And when we look at the numbers, they've been used about 500,000 times in people. So about 500,000 lives has been saved because of that. Now, we're also bringing barriers to treatment. We know that X waiver, a special, you could prescribe all opioids you want, but someone needs help with addiction, then you had to have an X waiver, a special license beyond the DEA license. I had that. But then President called out Congress passed legislation, President signed into it. No, we don't have X waiver. But removing one bureaucratic barrier, we've gone from 128,000 providers to almost 2 million providers across the country to be able to provide prescription. And then we're going after the drug traffickers. I was here in Miami, there's the Coast Guard cutter. We saw the offloading of 30 tons, or more than 60,000 pounds of cocaine from that cutter. And because this is what they catch, and that's the catch in a month. They're out there for a month, they catch, they bring people and drugs, and they destroy them. Now, we also knew coming in, we had a data problem because people, when they focus on non-fatal or fatal, they're not focusing also on non-fatal. And we knew that non-fatal overdoses were far outnumbering them. Think about this as mini strokes versus strokes. Think about this as chest pain versus heart attacks. It's the same kind of concept. Every overdose is a cry for help. And too often those cries go unheard across the country. So we worked with, interestingly enough, Department of Transportation. Because interestingly, when someone makes a 911 call, that goes to your county 911 system, EMS, that goes to the state, and that goes to the Department of Transportation. So we went to them and we said, listen, we know you've got the data, can we work with you? And partnering with Department of Transportation, we put out a 911 near real-time data tracker. You all have access to this. You can pull this up. It will give you, with about a week or 2 weeks lag, at a county level data of how many overdoses are being called, who's responding, who's not, what is the lag time, and the demographics. So this is as good as it can get with what we had, but it's important because, for instance, here in Jefferson County, the non-fatal overdose rate is much higher than the national average. At the same time, it's true for Alabama as a whole. But I also know that you're working towards that to put naloxone out there. That's the good news, because this also helps make good policy, data-driven policy, which is really important. Now, speaking of naloxone, let me say this. We know that if we put another 6.5 million doses out there across the country, we can save additional 26,000 lives. We know that. So we did last month, we put out a White House challenge. It's called the White House Challenge to Save Lives from Overdose. We're calling in every American, public and private sector, to come together and make sure that you're working to help ensure communities are ready and have access to saving lives. So I'll give you examples. We got commitments from airlines like Delta and Southwest. We got labor worksite, entertainment companies, school districts like LA and Atlanta public schools, transit systems in Boston, Philly, New Jersey, San Francisco, travel communities. They've all committed already to this. So what does that mean? Well, that means that in a county near where I live, they had an overdose death of a child in school. And then they decided they're going to have naloxone in all the schools of the county. It doesn't have to be that way. It doesn't. So now when LA school district put out naloxone, they've already had 50 times their saved lives. 50 already. So we know that this is not an enabling thing. we also know it's a life-saving thing because when you look at the data of doubling of overdose deaths in adolescents, I believe from 2019 to 2021, in 2/3 of the cases, bystanders were nearby and naloxone was not. And it's heartbreaking. It's heartbreaking when you see that young people are passing away because naloxone is not available. So again, I appeal to you to think about how to make it more accessible. Now, we must also recognize addiction as a disease. So we are creating this cascade of care for substance use disorder, which includes training, curriculum development, and that's really important. And here's the good news. When it comes to treatment across America, we've seen a dramatic change in the last 3 years. President Biden's invested more than $82 billion. $82 billion. That's 41% more than the entire previous 4 years. The reason this investment is important is because we've got to be able to save lives. But it's not only about funding. It's also about increasing access to people and meeting people where they are, when and where they need that help. And today, I will tell you that treatment for opioid use disorder is more accessible. We have methadone mobile vans, and we have treatment in jails and prisons that is growing. This is a criminal justice arc. We're working on deflection laws, we're working on drug court, we're working on drug treatment during reentry and equity in law enforcement. Why? Because every single day, there's 2 million Americans incarcerated. 66% of them are because of drug use. And 90% of them will come out, will get out. But what happens? The likelihood of them dying is 129-fold in the immediate days after release. So it's important to have treatment behind the walls. This is also the reason that the president took action to pardon marijuana, simple marijuana use or possession, as well as make sure that we're looking at ways to, and really has eliminated the disparity, sentencing disparity between crack and powder cocaine. So there's a lot of work happening in terms of equity in law enforcement as well. Because all of these things we talk about, your state now in Alabama has the ability to file for 1115 waiver that will get Medicaid started 90 days before reentry. That's a game changer. It will help, and it's one of those that is a bipartisan issue as well. Now, let me talk a little bit about making it easier for people to get their lives back, because it isn't only about naloxone or treatment. This is about recovery and lifelong recovery. We've got to help also make it easier for people with housing, transportation, childcare, employment, education. Supporting these wraparound services that I mentioned can help maintain people in long-term recovery. So we're now working with businesses to make them recovery-friendly businesses. Recently, Google has become a recovery-friendly workplace. We have iHeartMedia. We have so many other businesses that know it's good for the bottom line to recruit people and to keep them and help them. And there's more than 20 million Americans in recovery today, 60% plus employed. Now, how do I know that? Well, because we have people in recovery in my office that are working. So the hardest, most dedicated workers that we can see. And then prevention. I don't want to talk about everything without prevention, because prevention is one of the most core pillars of public health. We have a Drug-Free Communities program that covers 1 in 5 Americans across 50 states. And we're really expanding resources for schools to think about primary and secondary prevention as well, and really increase the resources. We've also put out this Real Deal on Fentanyl.com, Real Deal on Fentanyl, where we have social media that young people are talking to young people, not folks that look like me, but young people in their own language say, hey, 2 messages. Stay away from fake pills, because when you purchase pills like Xanax or Adderall online, they're 7 out of 10 going to be fake pills. And number 2, carry naloxone with you. And then we're not giving up on making sure that we're disrupting the drug supply. I mean, let me ask you, 90% of the fentanyl that comes in comes through our legal ports of entry. Legal ports of entry through vehicles. Now, can anyone tell me, what do you think, how much of those we scanned from a southwest border? Anybody just shout out a number, you think?
1%.
So 5% overall. And again, this has been over administrations in the past. And the president wants to make sure that 100% of those vehicles that need to be scanned get scanned. And that's why we're asking Congress to fund drug detection scanners at the border. So this is not about politics. This is actually about putting good policy in place. In this picture, you'll see here, down there, there's a big tunnel. That's a tunnel on your left-hand side. I was in there. You could drive an 18-wheeler through it between US and Mexico and Arizona. And we have to safeguard the tunnel that has been in the past a source of trafficking. So there's those things that are happening that we're working to make sure. We're also making sure that we are disrupting the commerce of drug trafficking. So it's one thing to go after traffickers only, but it's another thing to hit them in the pocket. And that's why the profit attack is so important. And that's what we're doing in addition. And then we're looking at threats of the future. I mentioned xylazine to you. We're also looking at others like nitazines and other substances. But let me tell you, while there's so much more work to do, all these efforts are making a difference. If you look at this slide, in just 2 years, we went from the highest percentage increase in overdose death rate in 2 decades to one of the lowest increases. And you know, in public health and epidemiology, kind of have to look at a curve. This is the flattening of the curve, statistically speaking. And it's a great sign that our efforts are working. Think about a large ship in the bay. You have to slow it down, stop it, and turn it around. Same in epidemiology, you have to do the same thing. And the drug mortality rates in 2022, for which we have the most recent data is for 2022. So the drug mortality rate actually decreased for people 15 to 34. They decreased for people, as you can see here. As I said, this is not your parents' epidemic. But what we've been able to accomplish in just the 3 years is remarkable, but we know now that what works, what is working. So what we have to do is double and triple down on what is working, and then make sure that every life is something looked at. And we keep the true North Star at saving lives. Lastly, I want to talk a little bit about, what are your roles? Let me tell you, this is not going to get fixed unless we're all with our, all hands on deck approach here. You are the future of public health. UAB helped me be prepared for the challenges, as I elucidated to you, some of them that I faced. So I would say to you, learn as much as you can while you're here. Make sure you apply these skills because they can take you anywhere you want to go. And then you can make a real difference in your community, your state, our nation, or our globe. The sky's the limit, truly. But here's what else you can help with. You can help us get surge and carry naloxone. Look at the realdealonfentanyl.com. Make treatment available. Work with law enforcement to disrupt trafficking at every turn and prevent substance use. Now we can do this. What the data has shown is this is possible. And as public health leaders, you're going to make a difference for so many people that you will never meet. That's the special thing about this. And that is the greatest gift that you can give to your community and our country. So thank you to your commitment to public health in Alabama and all across America.